Hey, everybody. It's the fourth week of the second year curriculum for low back pain for the Africa Rehab Fellowship. I'm Andy Haig, and we're going to talk about weird stuff. Here's somebody. Now, this is a man. I had a 69-year-old woman who came to the clinic saying that her head falls to her chest all the time. She had some midline neck pain too. An exam, she nodded off during my rant about variations in paraspinal muscle anatomy. I don't know why she could have gotten bored with that, but her eyes were wide open. What's it called when somebody can't lift their head? A couple of choices. Severe vertebral subluxation from rheumatoid arthritis. Just saw that last month, actually. Maybe she's hysterical. Actually, I'm not joking. In World War I, soldiers had this kind of a complaint where they bent over and couldn't stand up. And it turned out it was a mass hysterical conversion reaction of guys that were crouched in trenches and didn't want to go get killed. Maybe she's just hysterical. And my biggest concern, of course, is she had caught head syndrome instead of the real answer, which is called the dropped head syndrome. Okay. Here's another person that kind of feeds into this. This is a man I remember well, former professional tennis player. And a few years ago was playing tennis, and over time got to the point where after about 100 meters, he really couldn't keep walking. He had to stop, couldn't play tennis anymore. So now I'm always telling you, don't look at the MRI first. Don't look at the MRI first. And you shouldn't, because this guy looks like spinal stenosis, right? And I don't have his pictures, unfortunately. But look at this MRI. Yeah, look at that MRI. And for the cross-sectional shot, take a look at a normal MRI. And here's what I notice. Take a look at the multifidus muscle, okay? It's not atrophied. Atrophy can come from disuse. It can come from denervation. It is replaced with fat. Compare it to this normal multifidus, right? Black. It's a two image on the MRI scan. Compare it to the normal iliocostalis, which, by the way, even with this fatty atrophy disease, the iliocostalis is quite nice, right? Well, when you think about fatty replacement instead of atrophy, you think about things like Duchenne's muscular dystrophy and the kids with their calves and stuff like that. Well, this is one of those. This is bent spine syndrome, okay? And it's a myopathy, usually, focally of the paraspinal muscles. You never notice it unless you look at the paraspinal muscles. And if you did a spine clinic every day, you'd find one once a month. That's how common these things are. But they get missed all the time. So watch and see. Here's my iliopsoas. So both the dropped head syndrome and the bent spine syndrome, you can do an EMG and there's decreased insertional activity because there's no muscle fiber, it's just fat. And if you're around the periphery, you see myopathic motor units. And there are a whole bunch of different diseases that can cause this. Some of them are nerve, like ALS and post-polio syndrome. Some are neuromuscular, like myasthenia gravis. And what we'll see commonly, if you end up going to get a muscle biopsy or something, is a mitochondrial myopathy. There are all kinds of other myopathies that cause this. Parkinson's disease is more of a central nervous system disorder that has this as part of the problem. But the point is that especially with bent spine syndrome in the low back, you keep an eye out. And if you are doing a pretty constant spine clinic, you'll see cases. It's not rare. So what do you do with these people? What do you do with somebody who has no back muscles? Okay. Well, having no back muscles is no problem unless you've got to carry something and then you fall forward, right? Wow, old people sit for a long time. They all get hip flexion contractures. When you look at the kid with Duchenne's muscular dystrophy who's got weak proximal muscles, usually guys, he is leaning backwards to keep his center of gravity backwards and lock up his hips so that he doesn't have to use those very proximal spinal and gluteal muscles. An old person with an hip flexion contracture would love to do that, but they can't. So, of course, what do we do our guy? We stretched him out pretty far, and he could do well. Okay, we got better pictures in this article we wrote. Okay, 44-year-old guy with a chronic mechanical kind of back pain, he'll get a sudden ouch catch in his back. When he's coming up from forward bending in the clinic, it hurts. Going down is not so bad. He's done good physical therapy. He's done facet injections. They do relieve his pain for a short time, but he's in a lot of pain. He is significantly disabled. The surgeon says, fusion, fusion. Yeah. What's your reaction to that? Well, the frequency of lumbar fusion is absolutely scandalous. I think that the Dartmouth group showed that the chance of getting a lumbar fusion varies 20 times depending on which county you live in the United States. And that correlates with how many surgeons live there, how many MRI scanners they own, has no correlation with the actual pathology or age or anything like that, right? And so when you read the literature on fusion by surgeons, parts of it are really, really crazy biased. But I don't want you to ignore the fact that this procedure has a place. It's just really hard to sort out. So, is it useless? Well, a lot of experts will say it is. There are a lot of very good conservative surgeons who say nothing gets fused unless it's got neurologic deficit. Back pain, like our friend here, it's a fusion for mechanical back pain. Never, ever, ever. And Alf Nachemson, one of the world's great spine surgeons from Sweden, used to say, when I do a fusion, I'm replacing one pain with another pain. I'm just hoping my pain is less than theirs, right? And so this is a very difficult thing to support in most cases, right? But if you're looking at back pain and fusion, there's a potential that you'll do this in a spondylolisthesis. Now, spondylolisthesis of grade 1 or less has no correlation with pain in adults. So I'll teach you folks, if you have a person with back pain and they've got a grade 1 spondylolisthesis, go look for the reason for the back pain, because that wasn't it. Okay, another place where people treat the x-ray instead of the patient. It can hurt, but not in adults, okay? When it gets to more than 25%, gets towards grade 2 or 3 or 4, there's some correlation with pain. And in some of those people, they'll have really bad pain, they'll have neurologic deficits, and there's a place where sometimes after you've done everything else, surgery is very much the right thing to do. Severe degenerative scoliosis we'll get to. It can progress, and there are ways that you can look at it as a problem, and you could look at the fact that it's going to cause trouble in the future, and that adds up so that our surgical friends do some very good and very complex work. What about the real controversy? Segmental instability. Well, what is segmental instability? My very first research 30 years ago was because a surgeon named John Frymar wanted me to figure it out, because John did a study that showed that these flexion extension films don't prove anything. They don't correlate well. We're still trying to find out. But the surgeons who are interested in somebody who's got very bad pain and it's mechanical and everything else has failed are trying to justify what they're doing and trying to find more evidence besides their judgment, right? This is a good, honest, caring surgeon going, gosh, man, what am I right? They'll do flexion extension films, but unfortunately, my friend Allison Kegel, who actually lives here in Vermont again, and the Swedish group showed that people who truly have segmental instability splint when they flex and extend, and it doesn't really pick up the people we know have an unstable spine. There's another methodology where people put a backpack with some heavy bricks, maybe 10 kilos worth of bricks, and have the person sit on the x-ray table, and that may have some effect, but it's not that great. Sometimes, especially if there seems to be claudication or there's confusion, people will do a myelogram, because with a myelogram, you can have the person stand up and bend forward and backwards and see what's going on. But, in older people, if an MRI shows stenosis in 50% of people who have no pain, now you've added sensitivity. There is a place for it, because you're already jumping into the myelogram with a hypothesis and you're proving it, rather than going fishing and doing myelograms and everybody walking down the streets. But you can tell it's a problem. So flipping a coin might be better. Okay. So the idea is one of those motion segments goes forward on the other one because of lax ligaments. The facet joints in the back jam against each other. The holes where the nerves come out cause some pinching, right? And we just don't know how much motion. We know that it's variable in people who don't hurt. Then you have to ask, what makes it happen? And then you have to ask, what hurts? Is it the facet joint? Well, I know what to do with a facet joint, right? If it's the disc moving so much that the nerves are being pinched, you go, can I treat that non-surgically? Is there some trick I have in there, right? So what's really important, because of the literature in surgery, the bias inherent in surgery, and your expertise as a non-surgeon compared to our surgical colleagues who are really expert at doing the procedure, I like you to think that the need for a lumbar fusion is your judgment, not the surgeon's. This person's bad enough and symptoms make sense enough that I'm buying off on it. Hey, buddy, what do you think about it? Of course, a surgeon has to own it, and they do need to make the final decision to say yes, okay, or no. But there are these cases. We've had chronic low back pain. We have tried everything, put them through a rehab program. Psychologically, they're intact. Physically, we got them in shape. Nothing is working. And I've sent them to the surgeon who had said he wouldn't operate earlier and said, hey, take another look. Take another look. And they've done a fusion, and it's been the right thing. So don't cross it off the list, but you need to be very in control of what you're thinking before the patient goes to a surgeon, and it might be the right thing to do. So this is maybe a little bit older article, but I've got newer ones that say almost the same thing. Despite the effort of several authors to define lumbar spinal instability, no generally accepted definition is yet available. That's kind of where we're at with this. Hey, so I'm looking at this person's, this isn't my patient, but I had a patient like this. Well, take a look at this person. Take a look at their spinal cord. See some whiteness in the middle of the spinal cord? So that just because I printed it poorly? Syringomyelia? Hydromyelia? Oh, what's hydromyelia? This person has a clinically significant syrinx. You can see that big white area in the middle of the spinal cord. When we go backwards, and I'm not measuring it, this is a little thing here, a very little long column here, little long column here. And the first person, who was my patient, had rib pain. It wasn't a syrinx. And when we looked at the MRI scan, we said, gosh, that's a hydromyelia. A hydromyelia is just kind of a congenitally large central canal to the spinal cord. It's nothing. It's just how the person's built. A syringomyelia, often post-traumatic, but often not, is a area of the central spinal canal that has fluid in it. And when the person does a Valsalva or coughs or lifts, there's increased pressure, and it rips a little bit more, and rips a little bit more, and rips a little bit more, and gets bigger and bigger and bigger. So the person can eventually become tetraplegic. It can climb up into the brain and cause brainstem problems, and it can kill people. Okay, it's a nasty, nasty thing. We've known about both for 150 years, and you look at Dr. Leyden, über Hydromyelitis und Syringomyelie in Diagnoses. Yeah, never mind, it's in German. But that's where Leyden was trying to figure things out. So again, you often think of syringomyelia with a spinal cord patient. When a person who has a cervical spinal cord injury gets progressively weaker, among the wide differential diagnosis you have, among the other things, is, oh gosh, it could be a syringomyelia, right? Excuse me. But you can get these spontaneously. So again, hydromyelia is a larger than average spinal canal. So you don't want to overjudge hydromyelia. You don't want to ignore the possibility of syringomyelia. My point here is go find another cause of his pain. And part of it is because in his case, it was actually a rib. That's kind of easy, right? But also, this person's cavity was pretty small, so it probably was hydromyelia. I did a good, careful neurologic exam in the upper and lower limbs and found no spasticity. I didn't tell you that because it was a secret. And the fact is that if we're wrong, treating it can be really, really difficult. How do you treat a syrinx? Stop doing heavy lifting. Stop doing weightlifting with Valsalva, especially when they've got a coughing problem. Try to suppress the cough but it's pretty tough. Our surgical friends will try to open up the back of the spinal cord with all the inherent spinal cord injury you can imagine. They'll try to put a shunt in, but putting in a shunt doesn't really make the sudden pressure and ripping of a Valsalva maneuver or a cough go away, right? So it's pretty tough, and it can be a very difficult diagnosis. So what if you needed to prove that it wasn't a syrinx, right? Syrinx, excuse me. Again, upper motor neuron signs being normal, you're less concerned about it. Position and light touch are preferentially, because of where those carry in the spinal cord, involved in syrinx. So you're looking at vibration and position and light touch and all those fast fibers. And if those are normal, you're feeling a lot better. Somatosensory evoked potentials have very few uses. These are, because you haven't done EMG yet, many of you, repetitive little stimulations, let's say on the finger or the toe, with EEG electrodes on the brain. And you do 1,000 of them, and all the other things going on, like the thoughts of their girlfriend and their favorite color and the breathing and all that other brain stuff, averages out. But the relationship between the brainwave and the stimulus is fixed. So you begin to get a picture of a stimulus in the brain from the foot. So SSEPs have an interesting place there. We're pretty sure that my paraspinal mapping EMG picks up the paraspinal denervation, especially in the thoracic area. It might be useful. That we don't have data on a research trial, but we're pretty sure that's what's going on. And then sometimes you just wait and see what happens, right? Okay, 75-year-old man, take a look at his myelogram. What's wrong with this? Well, of course, you see that, right? See that white shadow there, right? Fooled you. It's not a myelogram. What if I told you he's from Korea or Japan or China? Doesn't have to be, but more likely than not. OPLL, ossification of the posterior longitudinal ligament. Okay. Really common in Asians. My friends in Hong Kong, when I visited them, they said they always have 6 or 8 people on their spinal cord unit getting surgery to open up the spinal canal, because the ossification of the posterior longitudinal ligament occupies more and more of the spinal canal, causing spasticity and stenosis. Okay. We'll see some cases in the US. You'll see some cases in Africa, especially because there are some Africans that will have it, but especially because there are Asians in Africa. The real punchline here is, if a person has neck pain, the first thing I do on my neck pain exam, the very first thing every time, is I check the Achilles reflex. If I see spasticity, I'm worried, right? So Achilles reflex, and then I go look at everything else. Some articles. Okay, this person has, I'll call it inverse spinal stenosis. 5 years beforehand, the 73-year-old guy had radiating low back pain, a positive EMG and an MRI that showed what MRI shows 73-year-old men who don't hurt: stenosis, disc degeneration, facet arthritis, right? By the time he saw me, that was all gone, right? So good thing the radiologist reading of stenosis didn't stick. But now he says that whenever he rides his exercise bike, he gets left leg pain posterior laterally on the calf, down to the lateral calf, switched to an elliptical, kind of a Stairmaster kind of thing, and the pain went away. But then he wants to get back on his bike, or if he sits for a long time in his chair, this pain down the leg goes back. Now that's inverse spinal stenosis, right? Because spinal stenosis, it's worse when they walk, and it's better when they're riding a bicycle or pushing a cart. Remember, right? So that doesn't make any sense. What's going on here? Could be spinal stenosis. Why? Because everybody's got stenosis, and I couldn't be proven wrong. Piriformis syndrome, because you've heard of piriformis syndrome. Okay. Pedal pusher's palsy, cyclic sciatica, unicyclist's sciatica. These are all real. What do you think? This guy had pedal pusher's palsy. I had so much fun with this. So I saw an obese lady here in Vermont when I was in my very first job, and she had had some back pain. And she'd been hearing all about our team's research on exercise, my senior colleagues' research. And so she decided she needed to exercise to get rid of her back pain. So she got on an exercise bike. About the same time, Bicycling Magazine had commissioned my friend Steve and I to look at seat pressures, asking how can people tolerate bicycle seats? And we knew that these fat, soft, cushy seats that you find on the exercise bicycles don't relieve pressure. They actually starve the butt skin for oxygen and make it more painful. So there's a reason why bicycle racers have these little hard seats, because their butt's moving off the seat all the time. If you really wanted to sit for 5 hours on a bike seat that's soft, you'd starve your butt for oxygen and you would be really sore. Okay. I took a look at this lady after I made a mistake, which is did an EMG, and back then I did a CT scan. I thought I knew what was going on. She had bruises on her butt. So I published it in the New England Journal of Medicine, and take a look at the article. It's great because every word had the letter P in it. We present prolongation and polyphasicity in proximal palsy perpetrated by pressure, possibly piriformis, in a non-proficient peddler. I got away with doing it all full of P's. But what really happened here was she was causing direct pressure on her sciatic nerve while she's sitting on an exercise bicycle. So that's called pedal pusher's palsy. But what am I trying to get at here? Piriformis syndrome is a corruption in history. Okay. It does exist. I've seen a few cases in my life. Okay. But the nerve doesn't go through the piriformis muscle more than 3 or 4% of the time. Okay. And so the vast majority of people couldn't possibly have it. Okay. The early cases in the 1920s and 30s were all people where that's what they thought was going on. And a surgeon operated on hundreds of people. They put them in bed. They got better, like a herniated disc would. And up until we wrote pedal pusher's palsy, there'd not been a single case in the literature that showed that the piriformis impinged on the nerve. Not a single good EMG positive case. There have been cases since. Mark Goddard wrote the first one after I called him out on it, and he's right. And I've seen cases. But your therapists will constantly think it's piriformis syndrome, piriformis syndrome, piriformis syndrome. Don't let anybody touch it surgically. It's a herniated disc or lateral recess stenosis, and you missed it on the MRI, or it's not sensitive. But guess what? All that's cyclic is not bicycle. So cyclic sciatica is endometriosis of the sciatic nerve. I haven't seen it. The OBGYNs do. And what happens is a person during their menstrual cycle will have periods where endometriosis grows on the sciatic nerve. They get pain down their leg. They can even get foot drop, and then it sloughs off and they do fine. And they'll do laparoscopic surgery and things like that for it. Guess what? All that is sciatica is not sciatic. So unicyclist sciatica is actually a pudendal nerve lesion. Don't think about it. Don't ride your unicycle that long. Even worse, cyclist palsy isn't even in the butt. If you ride a bicycle for a long, long time, you're going to compress your ulnar nerve at Guillen's canal, and you won't be able to lift the teacup. You'll have a distal ulnar neuropathy at the hand. And that's important because many people, the standard EMG will come to for ulnar neuropathy only tests across to one branch in the hand. And if you get this history of somebody having a lesion at Guillen's canal, you may need to test the thenar and the hypothenar branches of the ulnar nerve with your nerve conduction studies. So I've seen cyclist palsies in bikers. I've also seen it in people who smack cheese down as they're packing cheese, and some other funny jobs where people are slamming with their hands. People use hammers will get this. Bunch of references there. Okay. 42-year-old man with chronic work disabling low back pain on a whole bunch of short-acting opioids. What should you do? Convert to methadone? Get them on Suboxone? Taper and discontinue? Keep things as they are? Or make him join the Marines? Well, 6 years later, here's what we saw in the medical record. Unintentional overdose of methadose 4 years ago, found unconscious, blew at home, in a coma for several hours, then spent several weeks in the hospital. At this point, 4 years later, he had difficulty getting his words out smoothly, was unstable on his feet, weak in the left leg, slurs his words, poor memory, poor coordination. He lived. The others don't, right? So the point here is that drugs are dumb. For chronic pain, drugs are dumb. This guy got anoxic brain injury and a stroke when he forgot to breathe in the middle of the night, right? It's worth when you have opioids along with a benzodiazepine or opioids along with other sedating medications. And hundreds of people die from these every year. And it's not just people who abuse. This guy was using them in a benign, prescribed way, and he almost died. Okay. Transition from one drug to another, et cetera. People have sleep apnea put on drugs. They're really dumb. The biggest problem here, I think, is that people think drugs are miraculous. They are for blood pressure, for infections, for chemotherapy. And the expectation of drugs is so high that my Mexican friends say that they actually have patients demanding they get the medicines by an injection because it's more powerful than if they take it by mouth, right? And yet, when we look at the whole literature on drugs for chronic pain, every drug that you can think of that had any good research trial, Dr. Chu and others for the American College of Physicians and the American Pain Society found that no pill got rid of more than 30 or 40% of chronic pain. Most of these drugs for chronic pain are studied for a month or less, sometimes for a week. Person put, with chronic low back pain of 5 years duration, and in a 1 week randomized trial had a decrease in pain by 30%, and they declare victory. And you think, but I'm putting a person on it for the next 5 years, right? Yeah. So if the doctor thinks they can get away with more and more drugs, finding the right one, gosh, if I'm only lucky, I'll hope they'll come up with not gabapentin and not pregabalin, but maybe like pregabalin. Okay. If the doctor thinks they can get rid of half the pain, if the patient's expecting the doctor to get rid of half the pain, this is when you have people dying from our drugs, including the non-addicting ones. But you as rehab doctors need to be tough about this. What is really interesting, a study by Wallace, a randomized trial of non-addicted patients, and she was trying to figure out whether opioids help with pain, right? And people who had the opiates were no better than people who didn't get the opioids, but they liked their doctors better, okay? There's an editorial, did Ballantine write it, I think, after Wallace wrote this, it basically said something like this, for hundreds of thousands of years, this plant has survived by making humans eat itself and poop it out the seeds. And so there's a very tight relationship between this plant telling us we need to eat it, and anything that helps us to get the plant is going to be favored instead of something that doesn't. And so we're hardwired to like people who give us the opioids better. And as a doctor, that puts you in a difficult situation, not being liked. But dead patients are a bad thing. So there's also, and I think you know some of this, very high doses of opioids cause something called opioid hypersensitivity to pain. And I'll draw a parallel to the thing that they call fibromyalgia, because what they both have in common is a heightened sensitivity to pain. Okay. So if I pinch my thumb with 2 kilos of pressure, maybe it doesn't hurt. If I get to 10 kilos of pressure, it hurts. And what we know culturally and genetically is essentially all populations, all people tell you it hurts at the same level. Our bodies are wired to say that hurts at some level. But then the next question is, at what point does it bother you that it hurts? Like, I don't like this pain anymore. And that varies culturally. It also appears to be a hallmark of fibromyalgia. There are people who truly are suffering from the pain more than other people, right? And opioid hypersensitivity is like that. So a person who's on opioids, or a cat or a dog or whatever experiment they're doing, suffers and wants the pain to go away much faster. It's not psychological. It's not tied to depression. It's a physiologic response where your brain can't stop paying attention to the pain. So oftentimes patients on high doses for a long time, when they come off of them, actually have less pain. Oh, by the way, things like functional restoration rehab, which we'll get to soon, and we talked about last year, require people to stop the opioids. And over again, these kinds of multidisciplinary rehab programs that teach patients and empower patients and make them get rid of the drugs for a while and see what it's like without them have better results than the drugs. Okay. And just a couple months ago in Portugal, we presented a paper that shows that among the 50 American states, the ones who have fewer rehab doctors have more opioid deaths. No cause and effect yet, but we feel a real obligation as rehab doctors to not only find the alternatives to opioids, but also to teach our colleagues about the alternatives to opioids. Okay, we have ways to help our colleagues save lives. References. I didn't put my article in there. Yeah, oh well. Okay. 59-year-old woman with increasing left-sided back pain, which goes exquisitely, horribly into her great toe. I'll warn you ahead of time. This is one of those dumb cases where the back pain is her sacroiliac joint plus trochanter tendonitis. The toe pain is from something else. What do we call this? What do we call this? I've used the word before, the pseudo-radicular syndrome, right? Jeff Saul coined this word. People have mechanical back pain plus other causes for leg pain. It looks like radiculopathy to somebody who isn't examining the patient, right? And of course, this lady who has a problem down in her foot, the imaging of her spine, you'd expect it to show a herniated disc in a young person. You'd expect it to show spinal stenosis in an old person. You'd expect it to show degenerative joint disease and disc collapse. That's normal findings. People operate on those because their big toe hurts, okay? So take a minute, stop the computer. I'll keep talking here because you can pause this darn thing and I can't. Think of some causes for pseudoradicular syndrome. Well, you can talk about neurologic ones like a peroneal nerve palsy, sciatic nerve lesion, including piriformis, tumor, compression, squatting for a long time, right? Drug addict passes out against the wall squatting and they wake up the next day with a foot drop. Polyneuropathy, mononeuritis multiplexes, you'd think of it as little infarcts of this nerve or this nerve and that nerve, and it looks pretty focal. It can even be a radicular. Mechanical problems, like I've got back pain, I've got shin splints, I've got back pain, I've got some tendonitis. And how many times have I gone through my poem, right? Whip the hip, upset the facet, poke the troch, smack the sacroiliac. In this case, it was none of the things that I'd heard of before. She had great toe flexor tendonitis. And I bring this case up because I'd never seen it before. And this happens all the time. I've been around a long time. And do I go a month without finding something that I've never seen before? Sometimes something you could write out. I do. And the reason why I see it is because the rule in my brain is if I can't reproduce the symptom, I don't know what it is. Okay. So you got to use your physiatric braining. Well, I can't make the toe pain happen. I stretch my toe out and it hurts. It's sore, right? It was ridiculous when she showed it to me. So it turns out, using more of my physiatric brain, I'm looking at the biomechanical chain. She hyperpronated. That caused her to overuse her great toe flexors. So it hurt while she was walking. So she torqued on her trochanter and her SI joint. Her big toe was the reason why her back hurt. It goes the other direction. So orthotics, stretching the big toe, ice, a little PT to help fix the trochanter and sacroiliac joint, and have PT teach her how to rescue herself from episodes so she can fix it on her own. She did fine. Okay, next person. Lady comes into my office with this x-ray. Oh, wait a minute. I never met an x-ray I liked. What did she complain of? Well, of course, whip the hip, upset the facet, poke the troch, smack the sacroiliac. In people with that kind of scoliosis, though, sometimes you'll find the pain is because the rib is bumping into the iliac crest. And without puncturing the lung, you can sometimes inject that. And you can have physical therapy work with that, bracing, things like that. It may be that her body just gets really tired and she gets muscle aches because she's just trying to hold it up so much, right? It may be that scoliosis has caused the spinal canal to be really small and she's getting neurogenic claudication. So when a person with severe scoliosis comes to the office, you want to think of what's hurting, not just say, gosh, that's bad scoliosis, okay? And maybe you treat it. There are some things PT can do. There's a place here for braces. We don't talk about braces very much for back pain, and there's a controversy about whether back braces help with back pain. But you can stabilize her with a clamshell brace, with some other cash braces, others, and those can really help quite a bit. In a hot African sun, you sure want the kind that are light and careful. People play around with shoe lifts. Hey, if you think a person's leg length discrepancy is causing back pain, how do you tell how much to make the shoe lift? You use something we call the telephone book test, because we used to have these big old telephone books. You can use your anatomy book, it's all online anyhow, so you can waste the book. And instead of measuring the leg lengths and telling the person you've got a 2 centimeter leg length discrepancy, put on a 2 centimeter heel lift, it is uncanny how patients can tell you what feels right. Okay. If you overcorrect a body who's had a leg length discrepancy for 40 years, they're going to hurt when you make them look pretty on an x-ray. They're going to hurt because they're not used to it. Okay. So you get a telephone book or you get a book and you put it on the ground and they step on the book with one leg and the other one's on the ground. They go, oh, that's too high. You open up 100 pages, they step on it again. They go, oh, that's too low. You put back 50 pages. They go, yeah, that's about right. And then you look and you go, it's 0.8 centimeters. Let's do a heel lift of 0.8 centimeters. That's pretty spot on for what they need then. And if you and your therapist and time work for a little while, they may end up needing something different later on. So it's interesting to think about shoe lifts and scoliosis, but you'll often look at shoe lifts for other back-related problems. And it's not a bad idea, but it's not a measurement. It's a feel the patient has. Different injections. And then there's a place of surgery. And here we go again to, gosh, when does somebody need surgery? Well, not only might they need it for the current pain complaint of stenosis or severe pain or respiratory depression because of restrictive lung disease. Oh, I forgot about that. Yeah. But also, when you have certain angles, they're going to get worse. So you're looking at a 65-year-old healthy woman with just a little bit of osteopenia and otherwise healthy, and she's going to progress. And it's a tough decision. But would you rather have her fixed while she's still got some bone, or do you want to have it happen when she's 70 and she gets a compression, like that, right? So here's again where really smart surgeons are your very best friends. And here, they're actually probably more expert than us. Okay, they're really good at this, and this is a place where you and your surgeon come together and hopefully you can present the case to them, ruling out the other stuff. But there's a place where the surgeon who studies this and is a spine surgeon is going to know better. Last case. This is like your final exam. 70-year-old diabetic with back and leg pain. She's got low back pain. When she walks 50 meters, she gets leg pain and she has to bend over. She has a stocking distribution sensory loss. Her Achilles reflex is absent. And she's got a crossed adductor in the patellar reflex. She's got a jumpy patella and the other leg squishes over when you tap it. What's my first question I always ask you guys? The coroner called, she died. Well, there's her MRI. What did she die of? Well, whatever. I made up the case a little bit here, right? Her hairdresser killed her. Her hairdresser killed her because she had a cervical myelopathy. And those don't respond well to chiropractic, hairdressers, or American football. Okay? Spasticity in a low back pain case makes you worry. Okay, spasticity in a low back pain case makes you worry. That can't happen in the low back unless it's a tumor of the conus medullaris. It's a spinal cord lesion or it's a brain lesion. So what do? You go upstairs and you check reflexes in the arms. And if they're hyperreflexive, you go up at the face and look for focal cranial nerve problems. And if everything's spastic, you're like, yeah, you're just a jumpy person. Let's keep an eye on that, right? But if the arms are normal and the legs are spastic, there's a thoracic lesion there, right? If the arms are spastic and the legs are spastic and there's nothing cranial nerve, you at least want to cross through your head whether there is a cervical myelopathy or multiple sclerosis or something like that. So spasticity in a lower limb exam is not good. All right. I think I beat that up quite well. So what's really wrong besides this spasticity? Well, I think it's Osler or somebody who always come up with the unifying diagnosis for many symptoms. You want to go the other direction. She has many different provable causes. Stocking distribution is different from radicular distribution. That suggests polyneuropathy. It's probably diabetic, but diabetes doesn't stop you from being an alcoholic or getting thyroid disease or having a monoclonal gammopathy, et cetera, et cetera. So you at least pause and go, diabetic, yeah, but it's bad. It's bad, so I better check it out. Claudication with walking suggests lumbar spinal stenosis. Hey, you say, we're going to get to EMG, but look at an EMG distally is going to be abnormal with both those diseases. An EMG of the paraspinals It shows only L5 denervation, but not L4. Yeah, that's pretty good proof that you have both. The low back pain on my exam, it was their sacroiliac joint, right? Remember the rule I have, which is back pain from stenosis is not from stenosis in almost all cases, but not always. So my final slide, Jim Alberts, one of my favorite brilliant neurologists. Dr. Alberts, have you ever seen this before? I may have seen it, but I've never noticed it before. Your job is to notice. And with that, we will stop if I can.